It was a pleasure for me to present here at ASCO 2026 our study which looked at EGFR amplification and its impact on outcomes to first-line osimertinib monotherapy in patients with advanced metastatic non-small cell lung cancer with EGFR common mutations, or exon 19 deletions, or the L5R mutation. In this study, it's a retrospective study among 5 institutions across the US and Italy. We enrolled 473 patients with EGFR-mutated non-small cell lung cancer, and among them 17% had a concurrent EGFR amplifications defined as a copy number of at least 6 copies by NGS. This patient had some poor prognosis features like higher frequency of baseline brain metastasis, liver metastasis, bone metastasis, and also a higher frequency of baseline TP53 commutation. These were found in 80% of patients with EGFR amplified tumors versus 55% in those without amplification at baseline. When looking at the outcomes to first-line osimertinib monotherapy, we've seen that those with amplification compared to those without the amplification had a similar objective response rate, but they had significantly shorter median progression-free survival and overall survival, and this difference stood up even when adjusting for covariates in a multivariable model, even including the TP53 computational status. So it seems independent of that. We've seen that this effect may be more pronounced in patients having the EGFR exon 19 deletions compared to the L5R mutation, and this is, I think, is relevant because we think about exon 19 deletions as the group with the best prognosis with osimertinib monotherapy. So identifying a subset of these patients having poor prognosis is relevant for considering intensified treatment strategies. Then we look at how many copies of the EGFR there were in the amplified group. The median was 15 copies among EGFR amplified tumors, and the higher the copy number, the shorter the PFS, the shorter the overall survival. So there was an association between increasing copy number and worsening progression-free survival and overall survival. And even when looking at the mutant versus wild-type amplification, so we look at whether the amplification was mainly involved with the mutant EGFR allele or the wild-type EGFR allele, we've seen that patients with amplified mutant cancer had worse outcomes compared to those where the amplification involved predominantly the wild-type allele among the EGFR amplified group. So that's an interesting finding as well. And lastly, we look at mechanism of acquired resistance, putative mechanism of acquired resistance to first-line osimertinib among patients who had paired pre- and post-osimertinib NGS assessment, where we compared the two groups of EGFR amplified versus EGFR not amplified at baseline, so before starting osimertinib. And we've seen that in patients with baseline EGFR amplification, we found higher frequency of MET alteration at resistance was the 29% versus 12% in those without the EGFR amplification at baseline. So that may be important considering that we have 2 new strategies for EGFR-mutated non-small cell lung cancer that can include either osimertinib plus chemo or amivantamab plus lazertinib. And amivantamab covers MET, so they may be interesting to see if that can translate to some suggestion about which strategy to choose up front. So yes, in conclusion, our study characterized this subgroup of patients with EGFR with non-small cell lung cancer and concurrent EGFR amplification. We've seen that they have different characteristics, the metastatic sites at baseline, TP53 mutation, and also they have worse outcomes in general to osimertinib as first-line monotherapy.